Welcome to the Healthcare Plus podcast, hosted by Quint Studer and Dan Collard. I'm Nicole Webb-Bodie, partner at Healthcare Plus Solutions Group. Thank you for joining us as we bring together leaders and changemakers from across the healthcare industry. In each high-impact segment, you'll hear about the latest challenges organizations are facing and learn how guests are rewiring solutions to drive real change. Plus, you'll walk away from each episode with practical tools, techniques, and best practices to implement in your own role and in your organization. For more information on your host or to listen to recent episodes of the podcast, please visit www.healthcareplussg.com/podcast. Now, I'm pleased to welcome today's host, Quint Studer, who will introduce you to our next guest for a part one of a special two-part series.
Well, welcome to Healthcare Plus Solutions Group podcast. My name's Quint Studer, and I'll be hosting today. Really thrilled to have Dr. Gerald Hickson, Jerry, from Vanderbilt with me. He and I go way back. We can talk about that. I've learned so much from him. In fact, Jerry, just the other day I was talking about coffee cup conversations with someone, which I learned by you. I also learned the fact that we don't have to throw a big net over everybody when we can scale it down to talking to the people we need to talk to. Because I think sometimes in healthcare we're a little vague and we throw a big net, and the one that needs to hear it is not the one that's listening, and the ones that don't need to hear it are the ones thinking, are you talking about me? So, Gerald Hickson, MD, Joseph C. Ross Chair of Medical Education Administration, Professor of Pediatrics, Founding Director of the Center for Patient and Professional Advocacy, CPPA. Dr. Hickson serves as the Chair of the Board of Directors of the Institute of Healthcare Improvement, IHI. He also serves on the Board of Directors of KEC, USC Health System, the RLX Datex Customer Advisory Board, and is a member of the International Regulatory Expert Advisory Group to the Australian Health Practitioner Regulation Agency, AHPRA. Dr. Hickson previously served as chair of the board of directors of the National Patient Safety Foundation, NPSF. He's received his bachelor's degree from the University of Georgia and his MD from Tulane University School of Medicine. So, Jerry, you and I, again, I'm so appreciative of you and Vanderbilt. You know, I look back over my long history in healthcare, and I've got some of these places I've been able to be at, and I just walk out being so grateful. The thing I've always talked about Vanderbilt, and I remember being at one of your board of directors meetings, and they were talking about who they accept into the medical school. And it was pretty interesting because what I found out is they're looking for certainly the academic excellence and the intelligence, but they're also looking for the human touch from way, way back. I've told people I've gone to places where you have physicians that are clinically great, but might not be the best human beings in some elements of touch. Vanderbilt always gets both. And when I got my own melanoma diagnosis a couple of years ago, one of the first place I went to was Vanderbilt. So that for our listeners, I don't think there's any greater compliment you can give to a medical organization than that. So Jerry, you've spent more than 30 years at Vanderbilt working to identify and support professionals who have difficulty working with patients, families, and other medical team members. And I remember early on, because I go to your presentations to learn, you're showing metrics and you're showing like the majority of malpractice and complaints and cases come from a small group of individuals. And I've always tried to give people the benefit of the doubt that they don't want to be on that list. So what experience early in your career led you down this pathway?
But, we sometimes find ourselves in circumstances, gosh, we didn't choose, but out of the circumstance we learn or we're motivated. And so I had one of those experiences as a medical student that was something that disturbs me to this day. I walked into my surgical rotation as a third-year medical student and had been assigned to a senior surgical resident who was just unbelievably knowledgeable, great skills and ability, but was so abusive to other members of the team, whether the nurses, whether anesthesia, to the students that were there to learn. And gosh, it was a part of our culture, but not a very healthy culture. And one of the challenges, Quint, is that this individual who had an influence upon me, training me, sharing experiences that maybe I should not have seen in terms of normalizing disruptive behavior. But 8 years after he left his residency, he walked out and put a gun to his head. And the notion to this day that always disturbed me is that I saw behaviors that were things that we would and should not accept, that had become normalized because we just did not engage. And here's a human that had a mental health challenge that I wonder to this day, could he have been saved? Do we have an opportunity to contribute to a surgeon who's doing great work? Or was this a missed opportunity and a tragedy? That was one. Early in my professional career at Vanderbilt, I got an invitation to a dinner from the chancellor. And Ike Robinson was a great leader. And gosh, if you got invited to a dinner, I was not going to miss it. Being the young faculty member I was, and we went to this great meal, and there was a group of other researchers and leaders. And when dinner was finished, he professionally moved the staff out. I jokingly say he locked the door and then began to describe a challenge that had occurred at our institution. World famous clinician had been involved in an avoidable adverse outcome medical error. Patient had been harmed. But as he turned to all of us in the room, he said, all of us, including myself, saw this coming. Dr. X has performed, behaved in ways over the years that are difficult, creates all kinds of issues, and we did nothing effective. I talked to him, the dean talked to him, others talked to him. That was not sufficient. And I'm not letting this group out of the room unless you agree to begin to work to create an approach at Vanderbilt to early identify and address individuals that are having difficulty working with others, to redeem them, to keep them a part of the profession so they can be the best versions of themselves that they can be. And that's what started our work. And gosh, a few years later, we've learned some things, and we continue to learn things in our international network now of approaching 350 sites, a couple of 100,000 professionals who are constantly engaged in making medicine kinder and safer and helping each other along the way.
I have a column I write every week that shows up on LinkedIn. And, in fact, one coming up is exactly that. It's somebody being let go and me talking about why didn't we nip this sooner? Why did we wait? And we're going to talk about that. And that's one of the things I've learned from you. The other thing I've always learned from you is, yeah, you have great stories, but you also have great data. And I think that's combination of both is pretty hard to challenge. So with respect to the practice of medicine, talk about that, because you talked a little bit about, and I'm not sure people understand, are they disrespectful? Again, I'm a real benefit of the doubt person, because sometimes in a certain role, you never get addressed. So you don't know. You just you drift. You keep drifting. So talk about, is there any connection between disrespect in practice and patient outcomes in your research?
So, Quint, when I got started as a researcher, another one of those events that occur, we had a very prominent economist at Vanderbilt, Frank Sloan, great colleague, someone that I've worked with for a number of years, who was interested in an observation that he'd made. He did a series of studies in the state of Florida looking at this notion of whether malpractice claims were randomly distributed or if some individuals seemed to have a dark cloud. And what Frank identified, and Randy Boberg as a co-researcher followed up with, is that only 2 to 8% of physicians by specialty account for greater than 50% of all malpractice claims and more than 70% of cost. And as Randy Boberg showed, if you're high risk today, you're going to be high risk 10 years from now. And the question I got to explore as a part of the research team is why. Is it that these individuals are just seeing the most challenging patients? Is it that they are in a litigation-prone environment, or are there other things? And what our team sort of bumped into was that the eyes and ears of patients would tell us what we needed to hear. And your comment's exactly right. All of us, in terms of a medical environment, an engagement of care where patients may be anxious, physicians may be distracted in the moment, people may perceive disrespect. And so we want to do service recovery when a patient or family feels that we did not meet or exceed their expectations. But the question we ask is whether or not those reports, not standardized surveys, but reports that are offered to a patient relations office, whether they are non-randomly distributed. And what we found is that the same physicians who got lots of claims got lots of reports of disrespectful behavior. And within that group of disrespectful behavior, some of those reports are by individuals that were unreasonable in their expectations, but when the reports accumulated. And so we found that 3% of physicians will account for, approaching 50% of those reports. And we learned how to code them and aggregate the data so that we could then begin to share with individuals, your point, not only their stories, but their comparative data with others in their field. And we just want to be sure, Quint, if you happen to be one of those physicians who model disrespect, that I'm going to send a peer messenger into your office to say, Quint, you're an important member of this team. We're committed to sharing these data. The data suggests for some reason, we're not going to be directing, that there appears to be more associated with your practice. And all we're going to ask you to do is reflect on what you might do differently. Now, that's followed by a next step only if needed. And the great news is it's often never needed. That was what started us. And so when you and I first started working together, it was about respect. But what we've been able to do now with the accumulation of data, we can link our data sets to other national sets that look at surgical outcomes, that look at all kinds of medical outcomes. And what we're understanding now is that those same physicians who model disrespect have difficulty working with medical teams. And so they impact the ways that teams can work together. So we know now that the same physicians will be associated with 30 to 40% more avoidable medical outcomes, from surgical site infections to having to be readmitted to an ICU, to have sepsis and other outcomes. In a recent study, if you see a trauma team that models disrespect, you're 40% more likely to die. So it is not just how people feel, it's how that impacts the ability of the team to be working well together or distracted.
I've always remembered your stories and your data, because they're both to go on, but about the fact that, it's so easy for somebody to say, well, all the patients have high expectations. Well, that might be true, doctor. However, I just love the fact that you have the data. The other thing I like, and I'm getting off script here a little bit with, is the fact that, and I tell this story all the time about Vanderbilt, that you give the doctors time to have the data before jumping, because we find physicians need to sort of get used to it and look at it and go through some emotions instead of just surprising them. Here's the data. Let's talk. Here's the data. Let's talk after you've had a chance to look at the data. And you've always done that. Well, I'm excited about this next question, because I get this question and I've never known how to answer it. So now I will. I just got the question not too long ago. I was speaking, somebody raised their hand and said, what do you think about calling people providers? And that was the question from the group. So Jerry, you often make the point of talking about professionals, not providers. So in 2024 and beyond, what is professional, and how would you describe their responsibilities?
Quint, I'm going to suggest that what it means to be a professional was the same thing in 1847 when Semmelweis was trying to get people to wash their dang hands. I think it's the same thing in the 1970s when I entered the practice of medicine as it is today. And it is this notion that professionals have technical and cognitive competence. And I want to honor that. I want to expect that. We want to encourage that. But how much more we expect and should expect of them, given the trust relationship that should exist between that patient and the family that they're serving, given all of the fear and concerns that a patient and family may bring to that encounter. And so I'm going to suggest to you that professionals have a responsibility for a body of knowledge. They have a responsibility to continue to make that body of knowledge better as we learn more. And so when Semmelweis told us we ought to wash our hands, that was an alien notion. It didn't get embraced very well. And then in the 1970s, we were working on other kinds of challenges. And given all of the technology and advances we have, we're working on new ones. So we want to make it better and transition. We want to do what we do for the benefit of others. It's not the only thing that drives us, but it must be a major driver. And then the last thing that I feel very strongly about, and Justice Brandeis wrote about this, was our responsibility. And this is one of the things that I separate providers from professionals. Professionals have a responsibility to self-regulate. And what I ask people to do is once a week, maybe even more, is to pause before you walk into the emergency department, to the OR, to a medical unit of some sort. Ask the question, when I go in this door, am I going to make it easier or harder for other team members to do their work? Or do I make it more difficult? And in what circumstances then are we likely to see more errors? And so a professional regulates individual. And then when that's not done to our collective satisfaction, we have a responsibility to regulate as a group. And it's something we're very uncomfortable with. And until we get that part right, we still are not going to be the best practice of medicine we can be.
Well, I can't stop myself. I said I was not going to tell too many stories. My wife complains I story people out. But when I was president of a hospital, we were doing peer review and we were going over cases. And one of the physicians had a number of cases, kept coming up with the reason. And Dr. Ruby walked out of the meeting and said, I can't take this anymore. And then when I went to a place like Vanderbilt, or a place, again, lucky to work with places like Cleveland Clinic, I was amazed at how the physicians in those meetings were not afraid to question and challenge and address issues. I didn't know if it was the structure, I didn't know what, but I love the idea of professionalism, that self-regulation, and what you talked about in self-assessment. So that's marvelous. Well, you and your Vanderbilt colleagues, you've worked now. I worked with you. You are now so. When I worked with you, I think you were in the first inning, and now you're way down in the ball game here. But you work with so many other professionals worldwide. You've published hundreds of publications about how to identify professionals who have difficulty working with others. I just love the fact of that early identification. And that comes true of any relationship, not only in healthcare, outside of healthcare. How do we get it quick? And I always like to reward and recognize the good behavior as quick as possible so you get into the habit. Is it possible, though, because I get this question, does it come natural? Is it possible to change human behavior, these 4 to 5 to 3 to 5% of the people that tend to be the ones who dominate the malpractice cases, the complaints, and so on?
So, Quint, the answer is yes. It is for most, but not all. And so it's important to understand so that when leaders say we're going to launch a collective work that we're all participants in to make medicine kinder and safer, that's based upon a willingness to begin to share stories as they accumulate. And so I want to be sure that if today at Vanderbilt or the sites we're working at in Australia, a disturbance in the force comes in. I call it a disturbance in the force because a little humor. We don't want to take this too seriously. We all recognize that on occasion, I have a slip or a lapse, and I'm going to count on you to give me feedback. But the way the feedback's delivered, non-judgmental, respectful way, private, and there's some things we've learned along the pathway. We've learned the value of trained peers to go knock on people's doors versus sending the principal or a leader. We want to minimize the chance that we're fighting. We want to respect our colleagues and understand that all of us may be there. So therefore, Quint, I'm going to share with you a story. I know there are two sides to this story. I trust you to pause and reflect. And I'm not going to coach you. I'm not going to train you. I'm not going to diagnose you. But what we are going to do is continue to collect data. And the reports will either continue to come in or not. And if they come in so that there appears to be a pattern, we have developed what I think is a very effective approach to escalating the sharing, peer-to-peer, individual report, peer-to-peer with data. Now, as you made the point, nationally connected so that I can connect you with another 5,000 surgeons in your discipline so that you can see where you stand versus where others stand. And we're going to trust you to self-reflect. And the reflection occurs when I leave the room, not when I'm in the room delivering the data, but when I get out and let you think. And then if reports continue in that circumstance, now it's time in that tiered intervention model to now bring the leader in who we often found has not been adequately trained to understand how to get the best support for that individual, again, with a purpose. But I will tell you that of the small percent, now we're dealing with less than 1% that go to a guided intervention under authority, we still can recover better than 60% of those professionals who return back to the workplace and pursue the professionalism that they intended to begin with. And the very small percent who we can't may be individuals with a host of other kinds of challenges that need help.
Jerry, one of the things I was listening to as you talk, and again, those of you who have never heard Gerald Hickson present, he's a rock star. Well, I know you don't like that term, but you're phenomenally effective in your approach from individual conversations, group conversations, large national conferences, and so on. And I was thinking, as a physician, the time you've put in from high school to college to medical school to residency, it's not to not do well. But when you save and help a professional get their career on track, you're doing more than saving their life. You're saving thousands of lives of patients, of coworkers. So it's like that pebble in a pond. The impact is just absolutely amazing. So go ahead. I'm sorry.
And Quint, I'd like to add here, because we just gotten through a study that we've been working on 16 years. An orthopedic group I'm very proud of, geographically wide distributed across a couple of states. And very early on, they wanted to partner with us, and we created a program, a plan, training, infrastructure, everything needed. And we put it to work. And now, after 12 years after the first intervention to the present time, their malpractice claims experience has dropped 87%. These are orthopedic surgeons who have claims experience that's better than a general pediatrician. And the notion is that we can affect change, and it results in better outcomes. And so the notion is this is sort of an end result study where Frank started and said this problem. Let's understand why there's a problem. Let's act early and often to address and to sustain, because this is not about being here and being done. It is about us changing the way we engage with each other as professionals.
Well, Jerry, one of the things I've thought of today, and I get talked, there's not a lack of best practices out there. There's not a lack of knowing how. And I know I sort of move right now quickly through the why and the what, because people want to know the how. So recently, when I look at CMS reports, when I look at things, I'm going to use the term uneven. There's uneven performance in healthcare. And I don't think there needs to be as much uneven performance as there currently is, because there's probably not an organization, health system in the country that's not pursuing a culture of safety and respect. Yet some are having more success than others. So how do you start, but how do you sustain? So why don't you, if you could answer that, it's not an easy question, but we have uneven performance. Yet the answers are out there. If I was a hospital CEO, I'd be like turning off this podcast and calling Jerry Hickson right away. So I'll repeat the question. I assume people are serious about culture of safety and respect. So give some tips on how to start, if you would.
Quint, such an important issue, and we made 1,000 mistakes trying to get from the start of this work to the present time. But we've learned some things, and I'm willing to share most of those mistakes. But what I've learned is that, number one, you've got to have leadership commitment. But leadership commitment means that this is not a here today, gone tomorrow. It is an issue that we are going to link this commitment to our core values, our mission statement, and we're going to live it. This is what you taught at Vanderbilt that was so incredibly important, because every time, it's amazing to me, when we get a report today from a nursing professional who may observe me behave in some way that they believe is inconsistent with, they'll go back and say, inconsistent with our credo. Now, where'd that credo come from? Well, Quint Studer and his team came in and told us we needed a set of core values that we created as a group. So I begin to say, the leadership says, we're going to create a set of core values and what that means, and we're going to live them, and we're going to link that in to our performance evaluations, number one. Number two, it's got to be supported by an infrastructure. And that's really important. And that's what we've really got good at and help other organizations get good at. And that means that you've got an infrastructure with the right people, leadership commitment, a champion who owns the work and sees the linkage between behavior and outcomes of care, and an appropriate team to help support. It means linking it to an organization that clearly has that mission statement and will link policies and procedures for how we provide feedback. One of the things we often encounter in our work is that, many of the bylaws don't encourage non-judgmental, respectful sharing of coffee. It's either the truth or not the truth. No, I just want people thinking initially until the data accumulates. And then last, it has to be connected to the systems that will allow us to say, Quint, your behavior and performance seems, you hear that passive language, to be inconsistent with the performance expectation or your colleagues, and provide visual data so I can see where I stand in infection rates or return to the OR. And we use professionals' natural curiosity. And that really separates out those who can move from those unable to move, but we treat them with respect. One last comment I'd make here, and it's really important. I learned this the hard way. We've done some phenomenal work with reducing surgical site infections in care, and this pediatrician knows nothing about it, but I knew the numbers looked bad. And like yourself, I went and knocked on the door, and I got a volunteer, and they came back and said, well, the national data and the way we assess performance disadvantages us, and the coders don't really understand, and the coding's no good. And my response is, fine. We're a team. Let's pull, as we did a couple of hundred infections, and let's ask the question, are they coded right or not? Are there learnings here? Are we missing standardized best practices? And using the approach that we've used for patient complaints, we ran the process exactly the same way, and we have reduced our surgical infections by 60% that has now been sustained more than 10 years because the same approach. If Quint, we identify today that you missed an opportunity in the OR to follow our embraced best practice, somebody's going to knock on your door and share a cup of coffee. There may have been a perfectly good reason that you chose in the moment not to do something that we've embraced, but sending that message without allowing it to become hardwired is the key.
Harry, I'm nostalgia here. 20-something years ago, I went to my first clinical quality conference, and I was listening. And one of the things I've learned, the most effective conversations use the type of language you use. Help me understand. Because right away, you're giving that person a little, obviously you did something different than what we normally do. Just help me understand. And then the other words I love and use, something to consider. It's that thought process, because you give people in a way an exit ramp, but not an exit ramp to avoid the situation, an exit ramp to get back on the right lane. In fact, exit and come right back on an entry without the judgmental, without the label, until you need that. But you do all these other things first. So let's talk about now digging a little deeper.
Thank you for listening in with Quint Studer and Dr. Gerald Hickson. Tune in again next week to hear part 2 of this insightful conversation and learn practical ways to implement the solutions Dr. Hickson discussed. If you would like free resources and access to our latest books, articles, and industry insights, visit our website at healthcareplussg.com. We hope you'll join us next time as we continue our journey to make healthcare better for caregivers, patients, and communities.